after the AIOC, and basically we had developed a Google form with inputs from Dr. Anand and Dr. Azad, and the form was then circulated through our IROP WhatsApp group. And if you see, around at that time we had 226 registered member with the society. Out of that, 157 of them had responded. So if you see the guideline for any publication, if the survey has around 60% of the responses, it is sufficient enough to be published. The average age of our respondents was around 38 years, and most of our respondents were largely male, so no issues. But subspecialty wise, if you see, most of our practitioners, they have been either vitreoretinal surgeon or have been practicing medical retina. We have very few pediatric ophthalmologists who have been doing ROP practice for these years. If you see their practice settings, most of them are working with either private institutes or they are working with their own clinics, while many of them are doing in government as well as in charitable hospital. If you see the average years of experience, their experience in the field of ophthalmology or their subspecialty or their experience in working with ROP, it has been over 13 years for ophthalmology, and they have been doing it for subspecialty, mostly retina, for around 11 years, and the respondents, they had an average experience of handling ROP around 9 years. So if you see the pattern of ROP practice in their particular field, so they have been screening, the respondent on an average have been screening around 77 babies a month. They have been treating it around 4 babies a month, and among the babies who have been treated, they usually treat a mean of 1 baby per month. This has been among the respondents. So when we have asked about whether they use, so around 87% of the respondents are using anti-VEGF somewhere around the time to treat ROP, while there are around 13% of the people who are not at all using anti-VEGF to treat ROP. So the most common indication for which anti-VEGF is used by the members is basically either it is APROP or hybrid disease, or if the laser cannot be performed because of either hazy media or non-dilating pupil, or if there is a dense tunicovascular lentis. So these are the common indications. While what is the preferred anti-VEGF? So the most preferred anti-VEGF used by the members is bevacizumab, which is used by more than 50% of them, while ranibizumab scores the second, while some of them do also use biosimilars in their practice also. So coming to the settings for injection, most commonly the injections are given in main operation theater, while a significant number of them, they are also injecting it in NICU. If you see the type of anesthesia which is being used, most of them are doing it in under topical anesthesia, or some of them doing it under sedation. If you see the pattern of drug acquiring the drug, so people, if you take a generalized survey, most of them, they are taking it from direct vial, but from a single use. But if you, when I had asked for how do you obtain Avastin, more than 50% of them are taking it directly from the vial, and they are using it for multiple times. If we see what is the preferred dose of anti-VEGF that is being used compared to the adult dose, so most often around 80% of them, they are using half of the adult dose, while there are other variations like using less than 1/4 of the adult dose, but largely it is half of the adult dose which is being used. The preferred site of injection is either the inferotemporal quadrant or whichever quadrant which is easily accessible depending upon the baby's eye position at that time. And the most commonly distance from which the drug is being injected is either 1 or 1.5 millimeters from the limbus, but there are people around 10% of them who are also injecting it at around 2 millimeters from the limbus. If you see the treatment protocol, whether they are injecting the drug one eye at a time or both eyes at a time, most of them, more than 2/3 of the respondents, they are injecting both the eyes in single sitting. And for people who are not injecting the other eye in same sitting, most of them do inject the other eye by next 2 to 3 days. When asked about what is the follow-up schedule following up these babies after injection, most of the people, or around 50% of the respondents, they are following up this baby on weekly basis. But a significant proportion of respondents, more than around 1/3 of them, they are not following any strict follow-up guidelines. They are following up these babies depending upon the disease severity that they had seen. If we when asked about the type of consent that they are using, most of them are using specially drafted consent for anti-VEGF use in ROP, while some of them are using same AIOS or VRSI consent for anti-VEGF in ROP. But there are people who are using general consent, that meaning for general examination including to any kind of surgery. Around 20% of them are using general consent for ROP in baby. And does the does part of their consent include whether the drug that is being used is off label and we are not aware about the long term side effects of the drug. So most of the specially drafted consent, they are including this portion in their study, while there are around 15% of them which do not include any part of this as a part of their consent. So coming to the photo documentation and need for angiography, more around 63% of the respondents, either they do not have access or they are not doing photo documentation after use of anti-VEGF, and more than 90% of our respondents who are using anti-VEGF, they are not doing angiography to follow the vascularization after injection. So whether they are doing any systemic other kind of monitoring for neurodevelopmental delay or any systemic delay which can happen in these babies. So most of them are either not doing it, or if they are doing it, they are leaving it to the pediatrician to decide whether this baby need any kind of further monitoring. Coming to whether the respondents were aware of that anti-VEGF being they have specific guidelines for used in adult, but there are no such guidelines in neonates. So around 15% of them were not aware of the fact, and 96 of our respondents or group members feel that there is need for use of anti-VEGF at least for ROP babies. And when lastly we asked that whether this kind of survey or results of this kind of survey is going to alter your practice, so still most of them do not feel that results of this survey or consensus is going to alter their practice. But there are people who feel that if you come with some kind of consensus, this may also alter their anti-VEGF practice in current standard. Thank
you. Many people do bilateral trabs on same day. We don't do bilateral cataracts on same day because the incidence after endophthalmitis after cataract is little higher than after other surgeries. But if there is a baby who has congenital rubella syndrome, is very high risk, then we do the bilateral cataracts also same day. If they can't be anesthetized, again they come from NICU, then we do only once, or baby has a lot of fits or hydrocephalus. So we are quite comfortable doing that, and diabetic patients also I inject on the same day. So I think that if you are not comfortable doing it in other situations, then it's not fair to do bilateral injections in a baby. But if you are comfortable in other situations and you have enough experience and you're comfortable, then I think one can go ahead and inject both eyes same day. So like all other cases, for 2 eyes we change everything. We change the gloves, change the drapes, change the the vial or whatever. So that we do for surgery also, and that we do for adults also. So that's the only thing I want to say. So some of my colleagues, they don't do for adults, they don't do bilateral surgeries, they don't do bilateral Avastin for babies also. They do one day and then they call next day and inject on the next day. We also had a protocol where patients were not able to come next day. So we were doing one eye injection and other eye laser in the periphery, because anyway we have to add laser later. And then after 4-5 days, call back for injection this eye and laser in the other eye. So we found good results with that protocol also. So that both eyes get treatment on the same day, and we are not denying treatment to any eye, and we are shortening the total duration of the treatment. When you inject in one eye, the drug does go into the other eye, especially for Avastin. For ranibizumab, there's only 1 or 2 case reports where they've shown that it goes to other eye. But if you're giving Avastin to one eye, it is likely that the other eye is also benefiting in the interim.
I think they're asking, can you share the consent? Can you share the consent? And I think people are not very happy sharing it because they don't know whether that their consent is the right consent, and then it's like, oh, he gave it to me and so I'm following that. I think that is the trepidation. So I'm also giving some talk in another instruction course on consent, and I read up something about consent, so I just thought I'll share it here. I think it's relevant. There are, hi sir, we welcome Professor Dogra. He's our oration awardee this year. Please sir, please. I think, why don't three of you all go on?
It's nice to see such a good crowd for this meeting. To start with, congratulations. We've had a lot of volunteers from different states, cities, and this is like to create the awareness for the ROP program. In that, we have different states, and we have listed this, and the majority have been seen to come from Maharashtra is about 52. Why is it not scrolling down? Nothing is happening. Maharashtra is about 52. Second to that, we have Andhra Pradesh, which is 21, and no, sorry, Gujarat, which is 21, and Uttar Pradesh, which is about 21. And the thing is that what we are planning to do, we are planning to appoint sub-ambassadors from each state and as a referral point within the state, so that whatever activities towards awareness can be related to that ambassador or ambassadors from that particular state, and then they can put it on the national forum, so we know that the kind of activity which is happening all over the country, and we'll create a Google form in which we will be able to upload whatever is being done from everybody, so that it becomes a very collective kind of effort in creating awareness. One thing I would like to add is that probably India is the first one to create an awareness of this kind on a nationwide scale, and if this goes through in the systematic manner that we are planning, I think we will be the first pioneers to do this world over. Now, the other thing is that we have planned an information for parents and public, a form of a PPT, which I have sort of sent over to Anand and Sir for his ratification. We've added certain animations as to the procedures and in brief what the parents have to know about this information. And this will be circulated to all the members once it is ratified, and they could use this for their awareness propagation in their different cities. So what are the strategies we are looking for? We are looking for awareness amongst general public with general practitioners, pediatricians, gynecologists, optometrists, physiotherapists, other therapists, nurses, and allied health care workers. Towards this, we have already sort of in place a CME which we are going to be doing in the state of Mumbai, in the state of Maharashtra in Mumbai at my hospital, which is Bombay Hospital, where we have the target audience comprises of all these people, and we are going to like sort of create an awareness amongst these groups. Other thing is that we are looking at celebrities to endorse ROP, like how it is in the case of polio or sanitary pads. We are planning to get a few celebrities. We have a few lined up. I think in the month of March or April, we will be able to zero down on one and do it. To make it a state or nationwide initiative by involving the Ministry of Health, both in the states and in the country. Because the thing is that once that is done, life is very smooth because the advertising is taken over by them. See, at this point of time, the ROP society doesn't have any money. So whatever is being done, whether it is the creation of animations or whatever, is on our own, we are doing it with our own funds. But if it becomes a nationwide or a state initiative, then the state itself will help you in propagation of these awareness, whether it is to come at the back of buses or to come as advertisements or to come out as a health card. It's different things. There's the whole vista is open. Now, regular circulation of flyers on social media, platforms, radio, TV, etc. in regional languages, which each one can do in his state to create awareness in that locality. Distribution of posters depicting its seriousness. Conducting CMEs for groups mentioned above. Then conducting webinar on awareness for general public, where you can target general public and give them these kind of webinars. Standard protocol for healthcare workers on compulsory counseling with documented logbook for the same. Then standard PowerPoint for showing to general public, PowerPoint for general public to be distributed to all involved in the program, standard scripts in different languages so that people find it easier to understand, and circulation of animated videos which reach a heart sooner than any text would do. So this is one poster which we have just created 2 days back, 2 or 3 days back, and this was, we have done it for our hospital, one Masina hospital who's having an ICU just opened up and they wanted to create awareness in their hospital. So this was an idea which I thought I would share again with Sir and Anand, because if this is okay with them or they ratify it and the other executive board members, then this can be also put in circulation throughout the country to send the flyers to different places so that it creates a visual, very colorful kind of impact on the society. Now, these are certain PowerPoints which have been made towards this, and these are certain animations which we have done, where we have done about the treatments that can be done so that people know what is the kind of treatment which is given. Then a creation of stage plays. You saw one on the IROP group which Subhadra's student had put up yesterday. It was very nice. And similar kind of stage plays, we have asked some people to write out these stage plays, and there are a few, 3 or 4 which are ready, which need to be enacted and photographed. Songs depicting the same thing, translates of a uniform message in all languages, and you can already see on the board that there is something in Gujarati and Hindi. We have created one in Bengali and in Marathi. And these are certain slogans which are there, which also can be catch slogans like it's do boond like Zindagi ke. In polio, we have a similar kind like vision is our mission, or something of that kind, which becomes synonymous with the ROP theme. So ROP awareness has to be a household feature. Let's create it all, friends, and Jai Hind. Thank you.
Years ago under, let me just get to that slide actually. So this was created as part of the, and Dr. Rajan Shukla presented it during the VRSI. This was created as part of the Queen's Diamond Jubilee Trust for creating a competency-based training program for both screening and for treatment. And by treatment here, it was primarily focused on laser treatment. So we know that there are general ophthalmologists and there are retina specialists, there are pediatric ophthalmologists, and then there are retina specialists who during their fellowship have passed through some sort of training in ROP and some who haven't. Then there are also people who have been doing ROP for many years, maybe 15, 18, 20 years, but at that time there wasn't any formal ROP training. So where do we all fit in different levels of care that we all, eventually we want best for the babies, but how do we all fit in, firstly in terms of certification, and secondly now that it's becoming more and more legal, are we going to be on the wrong side if we just don't show that we are so-called accredited? So there is going to be a way of doing that, we hope. So this was the task force, the group that was headed by Dr. Jalali. And Claire Gilbert from London School, all of you all know her name, those who've been working in ROP, took a leaf from the Canadian system. So the Canadian system have probably done this the best in training their physicians. So we looked at that and we said, how can we adapt that to ophthalmology and then to ROP? Now this seems very complex to begin with, but I'll just assure you that it's actually a well thought out thing. So all these competencies are something that all of us do without realizing we are doing it. For example, if we have to simply tell a pediatrician that, you know, any baby, not a pediatrician, a neonatologist, that any baby born in your center who is less than 2 kilos has to have one screening before 30 days of life. Now, if you just look at what we have just done or what we want to do, it fits into these categories. Firstly, we are the medical expert. We are supposed to be the specialist. We know something about ROP. We know why we have to tell the neonatologist this. So it comes from a background of information. Then we are communicating. That depends on how we communicate to the neonatologist. Either he or she is going to listen or going to say, you can go to hell, I'm not going to send these babies, which were happening some time back. we have to collaborate with them. So that comes the collaborator. Are we going to go to see the baby there? Are they going to come to our center? So this is part of the collaboration. What kind of MOUs we sign in and so on. Obviously, the pediatrician has choices to send to. So if you are a leader in that area, then that's something that you will. And as a health advocate, now this goes beyond the role of the pediatrician. You will have to convince the mother, maybe other physicians, maybe the nurses, maybe the government, or maybe somebody who's going to ferry the baby up and down. And then you are constantly updating yourself. Today it was 1500 grams, 1 month later it's 2000 grams cut off, so you're also the scholar. And finally you have to be ethical, because you're not going to be, so that's the professional part, you're going to be doing ethical screening and ethical treatment. So all are these, and all in the center is the fact that we will be the ROP specialist. So looking at all of that, each of the competencies in terms of screening, treatment and follow-up were broken down. And we then created for each of these, what does it take to do a complete either a screening, and this screening could be through indirect ophthalmoscopy, could be through imaging or whatever. And what are the tools we need, what is the information we need, and how do we make sure we fit into all of these parameters. And more importantly, how do we test somebody to see he or she is good at those parameters or lacking in some. And finally, what should be the score to call somebody trained or partially trained or untrained. And I think based on that, then the certification will be given. So plenty of, so this has taken almost what, 24 months, ma'am? Yeah, 18 to 24 months to create. So I'm not going to attempt to summarize that now. What I will do now is, well, just to show you what all can be done. So we created a whole lot of a question bank. We created a library of documents that was most updated. We created play roles, clinical scenarios, videos, so on and so forth. And for each of these, you can see that leader, health advocate, so on and so forth. So what I'm going to do now is quickly go to the logbook. Yeah, because I think that's relevant, because this is something that we would want our trainees or maybe us ourselves filling it up. Oh, it's not come. Can we have screen यहाँ पे बदल गया है.
ये आगे नहीं चल रहा है इसको.
यहाँ पे चल रहा है.
नहीं चल रहा, यही वाला है.
अच्छा, ये जो यहाँ पे है वहाँ पे नहीं आ रहा है. ये पुराना.
उसमें आपके डुप्ली उसमें चेंज करो, इसको मिनिमाइज करो. ये एक्सटेंड में,
We are redundant.
एक्सटेंड में होगा तो तब भी आप यहाँ पे एक्सटेंड में मत करो.
अच्छा. Okay, so I'll go a little slow on this, but I'm just going to spend another 5 minutes. So personal details of trainee, training details, and treatment details. So somebody can come to you for only getting trained for screening or treatment or both. So this is like going to be a logbook, and it's going to have like an operational manual. And more importantly, we've added the component of self-assessment. So at the end of the day, it's okay we saying somebody is trained, but if that person doesn't feel confident enough, then maybe we should go back and look at it. So this has come with some consensus, and we are open to suggestion. How many babies is enough for somebody who is, of course, they have to be sort of oriented to doing it in adults, maybe a little comfortable. It's not like you're taking a first year postgraduate, but 50 eyes is sort of a pre-thing to do indirect ophthalmoscopy in adults before you even enroll in the ROP's training program. And I don't know whether that's fair enough, whether we want to make that 100 or less than 50, but that's a thought. Then pre-screening preparation, where you are sort of unsupervised doing it just to make sure that you're on the same page. And then 50 eyes that you screen with indirect ophthalmoscopy. If you've enrolled for an imaging base, then another 50 eyes, which is about 25 patients, not too bad. And then laser treatment 10. Okay, so we thought 10 should be the minimum, and some of our fellows, who've been doing adults for so long, they get very comfortable with even 3 or 4. But 10, and preferably one of them should ideally be AP-ROP. But that's, it's not nice to hope like that, because that means some baby has to have that disease when they come to you. And this is the final sort of like every logbook has a sort of summary of when that was done and who signed it. Okay, so here's an example. So we are looking at, assisted, supervised, and independent. Okay, I think that's self-explanatory. So let's look at that now. So screening for indirect and for treatment. So what are the instruments you need to have? How do you use it? What's the procedure? What is the how can you detect that you made a complication? How do you detect and how do you deal with sick babies if they're getting while doing the screening? How do you interpret your findings? Super important, how do you communicate it, which means both the written communication into the file and to the mother and to the pediatrician. And what will you do next in terms of follow-up? What do you do with this baby in terms of coming back for screening or not? So it slightly changes for laser. Indications, consent, super important. Counseling, that is obviously before treatment, which instruments you use, how do you monitor during the treatment, how do you actually do it, how do you identify skip areas, maybe immediately or even a few days later. When do you decide and how do you decide a baby needs retreatment? What is your follow-up schedule? How do you decide that this is a favorable or unfavorable outcome? And how much do you know about adjunctive therapies and how comfortable are you providing them? So we think we've covered it all, but you may not have time to give us your suggestions now, but please put it on the group because this is not the final document. The mentors have seeing it, and it will eventually become something which we will send out the PDF to all of you all, and you all can decide how you all want to incorporate it in your practice. Many of you all are in teaching institutes. So these are exactly the number of columns left for the numbers we said they should do. So if it's 10, 15 or 20 babies, and those same tasks are written here. So if it's a communication, they should know how to communicate with the parent, nurse, pediatrician, neonatologist. Documentation will be listing, tracking, inpatient record, ROP card, discharge summary, drugs, which ones to use, pain relief, safety, how do you wrap the baby, how do you monitor, and the same thing. So this is a little bit up for debate. Can we call somebody partially competent? So there was a question in VRSI. Maybe we say competent and requires further training, just because we don't want to obviously hurt anyone's ego. And by partially competent, we anyway mean that come back for a little more training. So why label somebody? And then also the legal gray zone. If you say somebody is partially competent, so what? Are you allowing him to do it or not? So that so we're going to probably remove the 3 tier here. And definitely we're not going to have something called low competence. This was a suggestion. I think this is what the Canadians used for their system, but we don't have to use all of it. So this is in the adults, and the questions will come accordingly. The indirect ophthalmoscopy for about 50 babies, so that goes, the logbook goes on. Imaging system for those who are going to be in that. So obviously the questions here are a little different in terms of how do you use the software, look at videos, stills, how do you communicate, how do you store these images and so on. And I think I have laser also. Yeah, so laser. So indications, are you able to diagnose type 1, APROP or hybrid? What are the consents? What's the counseling? What are the instruments you use? How do you monitor? What's the procedure in terms of power setting, duration, interval, laser spot? How do you identify skip areas, retreatment, follow-up, outcome, and adjunctive therapies? Again, the same thing, the A, S, and I. So for every patient, the mentor will decide whether it was assisted, supervised, or completely independent, and then we're going to have a score. So you have to have 40% of independent or 30% of independent. And these are the summary tables of all of it in supervised and independent, and then there's a score, and finally from the score. So this is the self-assessment. In the self-assessment, we have this, confident to always undertake without ongoing support. Obviously, we want all our candidates to reach here, but that may not be possible in the 2 weeks or 3 weeks. So confident usually to undertake without ongoing support, will require ongoing support in all cases. So our idea is that if somebody was honest and has written this logbook, majority of the scores are here, then we will tell them that, extend your training. If a majority of them are here or even here, then we can say, you seem to be confident enough, go ahead, and then we can give them, and we can match our so-called competence and no competence with what they think they have. And of course, this is all going to be viewed, and every case they see, you're going to be there. So technically, they should match, and eventually we should be able to give the certification. So, yes, please. Yeah. Ma'am, you want to take that question?
We'll add that I think the era is that people should know how to give it, because whenever we are giving, they should know how to give it properly, because people are giving, and we also believe that in certain cases we have to give. So I think we will add that.
I think we need to add that because people are still giving 2.5 millimeters away from the limbus.
Yeah, so better to do it properly rather than to hide under the carpet and say we are not giving. And we have also come up with guidelines, and the data shows that there are cases, and it's better to teach that than people to learn the wrong practices.
Yeah,
So
yes.
I think we'll add that. So we said that they should have done at least 50 indirects. So people who are already doing retina surgeries and all, we don't need them to do. But we do have people who come from pediatric ophthalmology or who come from comprehensive ophthalmology. So if they can get information, maybe they have an old logbook or they're already doing, or at least we want that there should be an evidence that they know indirect ophthalmoscopy. If they don't know indirect ophthalmoscopy, still we teach them. But the thing is, we cannot teach them lasers. And then if they come for training, we put them into adult OPD for 1 or 2 days, and then that is enough for them to at least practice their indirect and then take them up. So that's why he's put that logbook there. So if the teacher feels that that logbook of the 50 indirect ophthalmoscopy in the adult can be waived off. So you can say waived off because this person is already a fellowship trained retina surgeon and already assistant professor of retina surgery. So then you can waive that off. But for some people, we may not be able to waive that off.
At the outset, I would like to thank Professor Azad, Anand, and the entire executive and IROP for giving me this opportunity to deliver a oration which is on the name of a legend in ROP. This particular photograph was taken during World ROP Congress in Shanghai, and I was one of the judges among 4, you can see there, for the posters in that very session. You also see there Michael Shapiro, as well as Kondo, who came last time, and I think we've been very fortunate. I think Subhadra did a splendid job by inviting him, especially into LB Prasad, where this workshop was held, and how hard a person can work even at that stage. He had shown to us right from morning till late, and that is the time we all, you can see quite a few of us there up in that photograph. And we are all aware, the group here, we know that retinopathy of prematurity is a new problem, emerging problem. And we also understand, and that is what we have contributed probably significantly from this country, I'll come to that the higher birth weight babies are developing ROP in all the developing countries, not only in India. And it is becoming a major public health concern. And the best part is the blindness is, preventable in majority of these cases. I think these are the figures. That is what Anand alluded to, the first 2 studies, back to back. One from Lingam Gopal, another from us, from PGI. This was in 95 IGO. And that is where the whole thing started. And the incidence was somewhere 38 to, in their study, and 47. Our study was prospective. And that is what perhaps it was as a first thesis I had given to someone. And that's why I think it has, I was surprised. I'll talk to you about that later. And these are the numbers. These are the recent Lancet Globe Health. Talks about in terms of 490,000 preterm infants born before 32 weeks of, and 5,000 need some form of treatment for ROP. This is for our country. That is the way it has been put forward in this particular article. I think why I say Professor Azad is here, I think his contribution immense. I'll come to that later. Why I say this gentleman here, Lingam Gopal, is father of ROP. He started first of all somewhere in 1990. He started, and he came the same year to USA, and I was doing fellowship. And I already used to go, and he told me, you concentrate more. He started seeing, and he even told me that the lady who heads the Child Trust Hospital is also trained from PGI as a neonatologist. So you'll have maximum number of babies there. So I understood that. I concentrated, and I started working in 1991. That is the time I started my ROP work in PGI Chandigarh. And you see, we grew over the ages. This is in a ROP session in Agra. I think Subhadra and others would remember. I think we had a full hall. People were standing. We felt so good. And 95, this is the year we published, both of us, Anji. So I had gone to Chennai there, and even Tarun is there. Well, I think we owe a lot to Professor Azad. He changed the whole scenario. He brought it onto the national front. I can tell you where we were. I still remember my first presentation sometime in the first Congress, when somebody got up in LV Prasad, this senior gentleman, that why you are wasting young men. I was young that time, your time. So I said, sir, this is coming. Because we used to have retrolental fibroplasia as differential diagnosis of retinoblastoma. That was it. That is what we learned, and that we know it. So, but then, so I think Harsh Kumar, I have mentioned here, he doesn't do ROP now. He started, sir has gone those days to Kuwait. So he was doing work there, and he took up in RP Center that time. And he was even involved in the first book which he wrote along with Professor Azad and Michael Shapiro. And this was subsequently when I visited RP Center. You can see there Parijat, Rohan and others. I visited their team. I think that is where it started. When he started having peer workshop all across country, and this was first in the RP Center in 2001. And you can see here, Subhadra is there. We are all young, and many of the faces you can recognize are there. I think subsequently, a lot of work. I think Narendran is here, Parag with him. They started both of them in 2000. And they have done a remarkable job and remarkable work in this area. And so are, you see here, of course, Anand and that's their Parveen. I think Parveen and Parijat, they are stuck up in the course which is being conducted by Professor Atul Kumar. They are sitting right on the stage with him, so they're not even here. And of course, I think Subhadra does all the credit. She, in fact, has infused so much of life into everything as far as ROP is concerned. So this is what I was talking, the first two studies, and why I mentioned this, that our study, you see, when I was going through, since I was given the Indian contributions, that how much impact our studies have done. And it was surprising to me that out of all the studies which I mentioned here, our study has second best citations. This put in more than 100 for this particular study, because this was prospective. I think since Gopal's study was retrospective, that has fairly less, almost half. But Anand did this last study. This has caught up quite a big Hungi et al. This is in the rural area. This has caught up a lot of citations, and that is what I think only with the citations we are contributing perhaps to the entire nation. I think this is one article. I think this was Subhadra's idea, I still remember, which has got a lot of citation, more than 100 citations. And this particular article where all of us were, you can see here, Professor Azad is there, and of course, I think both Raj and Harsh, they are not doing ROP anymore. They moved to other area. We are still there. I think I couldn't believe myself. Anand is so lucky. This has the maximum number of citation on any ROP article written from India. This has almost so much of citations, which is unbelievable. I couldn't imagine. This has been cited everywhere. So Scopus even has more than 100, and Google Scholar has something like 194 for this particular article, which is amazing that so much has been. And I remember when this article was published, after that there was a study done by Beijing people, they talked to us, by Brazil people as well as by Indonesian people. So many people did studies after this. And of course, you know about this article, that is where the whole thing started, that 16% were more than 1750, 6.5% more than 2 kgs, and even 22% were more than 32 weeks. That is where we started questioning those guidelines. But you see, here we have this 2 article here. Of course, we published first on aggressive posterior ROP on 2009. This was also one of the first publication we did. And this Subhadra's article about twin cities, this is a landmark article, and so is this aggressive posterior ROP from Narendran and Prakshav's group. I think you remember, if some of you remember, I think this was in the World ROP meet in 2000 when Dr. Foster entirely based his talk on this article. Entirely based. It was so important. So I think we changed the whole thing. That's what happened. You can see the birth weights here as compared to the Western worlds and the period of gestation. That's how they started trusting us, believing us. They were not, they were saying we have gone crazy, perhaps. And look at this article by Subhadra. This has a lot of citation in American Journal. This had made a big impact because that is where she talked about changing or modifying the all the and this one again from Narendran, their group, which talks of bigger babies, and our article that time in aggressive posterior ROP, we first time had shown in 2009 in Retina that there are a lot of babies with higher birth weight babies. And this is that article. You can see here the 1572 grams in their series, which was published in Archives of Child Diseases. And this was the picture in that. I remember when he had shown this picture earlier to me, they had not written this article. And I mean, it was unbelievable. There are no vessels there. I have not projected, I don't have that. And they have shown with anti-VEGF and subsequent laser, this went to favorable outcome. And they had first time brought out this unblended oxygen as one of the major factor responsible for this. So how it helped us, all these studies? It helped us changing the guidelines. I have just put the American guidelines here. If you go through the entire guidelines, they are everywhere they are different. So we could make it 2 kgs in 34 weeks. If we don't have evidence, the biggest, all of us are sitting here, the objection comes from our neonatologist pediatrician. They don't want. They feel that too many babies require screening. I think I must congratulate Subhadra for giving this Din Roshni ke slogan, 30 days. People would remember it easily. And this is something which is very, very important. And all of us, we know, all of us sitting here are ROP expert. So I'm not even talking to you guys about these things, that we screen always screen the NICU. That's how you get to know them. That's how you get to know what you're going to counsel them. And that's why it's so important. And of course, I think these things have been talked, and we are trying to look at these things more seriously. And I must here talk about this KidROP model. And this is another article, I would say, which had made a major impact. Out of all the articles which Anand has written, as far as this program is concerned, this has the highest number of citations. And you see, this made a huge impact. Here, he is talking in terms of trained people. Those you train people, you train the technician, and they would screen, and he had shown high sensitivity, specificity. And of course, subsequently, the numbers have gone much more higher. And this kind of work, which he has done all over Karnataka, is a landmark work, is being replicated, not only in our country, many places, but in some other countries. Of course, we know about the treatment. I'm not talking about that. I'm not really going into that. The question is, I'm just going to be talking about what we contributed. I was trying to fish out some older pictures. You see, that is the way we did cryo. This is the cryo. I did first cryo, I still remember, when I did in October 91. And I think it was effective. Despite this nerving and all that, I remember this girl now. She has now grown, and I think she's got married, and the vision is still, she's a high myope, but vision is still 6.6. So that is the way. I think we used to did a good job even with those cryos those days. And of course, now the laser is the standard, and that is what, and the way we started also, I remember it is very difficult. We had to acquire one diode laser for our center in PGI. And in government sector, there was no diode that time. And they would say they need a benchmark, otherwise the government doesn't allow you a laser. I still remember, and this exercise was going in around from 95 onwards. And it took me 2 years till 97 when the first diode came, because ultimately they accepted some international benchmark. Then only it could come. Then that's how we started. Because that time it was strictly no, that you have to only use diode laser as far as the treatment of ROP was concerned. I think when Anand was with me there, we also learned that we could treat through the wall of incubator a highly unstable baby. And this we have shown many times and even screened through the wall. I think this has been a big contribution. That is what I say. Now everybody uses the same laser. This is a 532 laser. But how do you convince? If you don't publish, I think then it doesn't work. You need to show convincingly in a peer-reviewed, and that's why even for contribution in this June issue, I had told specifically my team here, and both of them are here, and I told both Diksha and Simar as well as other people that let's collect our own cases and put that, so that people believe that in large number it is sort of working very well. That's why we published in that. Apart from that, of course, 2010 article, which Anand is also part of it. Of course, all this is known to you. We do quantum laser. This is from the diode time picture. This is the green laser. That's how the green laser marks, and it works equally well. I think, again, Subhadra does again a lot of applause for getting all of us into this. And it was very important. I still remember, this was a World ROP. I think Narendran was part of that. When we were in, World Congress, maybe in Berlin, yes. Most of the European, it was full hall. We got very good response. They said, how come you can do without general anesthesia ROP treatment? So it was an eye-opener for them. And once we showed so many cases, this is first time they could not imagine. And for us, if general anesthesia has to be given to each baby who's so sick, it is not possible in this country. So I think it gives a lot of insight, and most of us sitting here, we are there. And another issue, most of our cases, outborn, we had already seen, they were APROP. And overall also, perhaps 50% are, or around that, 40 to 50% are APROP in this country. Whereas the Western countries, they don't see APROP. And not only that, we have a problem. We don't see any APROP from our own center in PGI. We have not seen in years. But we see, that is what they are seeing every day. Whichever baby is coming for treatment is APROP. I think many of you would concur, and that is all coming from outside. That's where the problem, so we need to know more about this. So the problem is, they don't have that favorable outcome. In our own series that time published in 2009, we had 71% success rate, because all kind of cases come there. And I think that is where we have, I think, contributed significantly to the world literature. Because I still remember when many of the people, they talked from Western countries, they said we see very few APROPs. So they were not able to raise larger series, except the one series, which is from the Michael Tracy's group. They published, in fact, in 2010, 1 year after us. So they were not seeing that many. So I think you can see we have quite a bit of contribution as far as this part is concerned. And that is where, again, you can see, even in APROP only, I have shown that chart in a different way later, but look at the weights. I wanted to look at their birth weight and period of gestation. So different. This is Michael Tracy's group only. Dressner is working, they're working together. And Azuma is from Japan. He's been also a great friend of ours and works for the Children's Hospital, Tokyo. And we also worked which cases, because so many were going unfavorable outcome. So with the posterior zone 1 APRO, or the pre-existing proliferation, or after that they go into APRO. I think we even put this hybrid ROP. This has been coined by us term, because we were not able to fit some of the ROPs anywhere. So I don't know what is the status Anand and Parag were there, whether they are going to include some of these things there or not. But anyway, we do see different kind of ROPs. And something like this, which we can not put large loops, as if something has been stuck there, it's not a stage or anything. And this is the first publication of posterior zone 1 ROP. Posterior zone 1, we called it, some people also call zone half, because zone half, the problem remains that it doesn't say zone 1. Zone half means anywhere, anything. So that's why posterior zone 1 to me appear a better term, and this term has also been used in anecdotal, not reports, but in between by some of the groups from Chile, as well as by Michael Shapiro and others. And so this is something, when we collected this also, these cases, you can see most of them, 79% had unfavorable outcome with laser. 79%. This is first exclusive publication also on posterior zone 1 ROP. So I think we need to contribute more. That is what we want to, and perhaps these are the type of cases we see. And you do whatever, even the stretch breaks develop later on. And once there are stretch breaks, then you can't even do, perhaps surgery is also going to be absolutely dismal. It's a problem. So I think these are the cases where we need to contribute, and we need to show that we need a combination treatment. And what are the results of combination treatment? If we give anti-VEGF, we do laser and early surgery, I think many of them, they can do better. I think I was very impressed. Recently, Diksha did one such case, and the Simmer has shown me all those pictures, where they did bilateral simultaneous surgery in such a situation. And I can't believe that these cases could look that good. That is the way to perhaps to go. So we definitely need to sort of move on to into that direction. I think I will make special mention of this article. Dr. Narendran, you will be surprised. In your group, this is the maximum cited article. This has got so many citations because this was a case report. This is a case report, but has more than 100 citations. And that is what even one case can make a difference. Because perhaps everybody, whosoever is giving injection in APROP, they would quote this, they'll go to this. That is what I can also. And of course, we are very proud. I think Parijat is sitting in the other hall, that they contributed to this Cochrane review 2018. You see, this is a big contribution from our, this thing, group in the sense from our country. And of course, lens sparing vitrectomy is something I think we have been propagating. I think early surgery we have been propagating, and that's very, very important. I think many of us, those who do surgery, must go on to this. And you can have result like this picture you have seen many a time. Even if it looks so scary, you just do vitrectomy, remove the vitreous, cut those little bands, and you will have an excellent outcome. And of course, you can see the contribution, our own, these are all our own, right from a group from Sankar Netralaya to the Narendran's group. Gadkari, he's no more with us. He contributed so much on the surgical part. You must go and look at his article. He has done such a wonderful job. You will get a lot of insight into many things which he started. And of course, recently Parijat also published a very good series of sequential ROP surgery at the same time. I think we've been looking at some things which we feel for many years. We are putting this trocar just up to the hub and don't push it all the way. And then just if you put inside and remove it, you will never touch. Otherwise, you will touch the retina. It's long. So that is the way we have been doing. And of course, we started doing this nasal, purely nasal, with a, I must say, because this is not written or reported anywhere, even if some people were doing, I don't know. But you put infusion in the center and these two ports from the side. And why? Because how do you spare the lens? Entire retina is so much lifted, it is behind the lens temporally. That is why it is so important to do.
Hello, Bhaiya. Hello.
Anyway, I think it was not showing. It's all right. Anyway, so you can see maybe some other time. So you see, this was a case which I would have shown a video which didn't somehow come up here. And you can see well settled retina. It was such a bad looking case if we had seen the surgery that ultimately you can see a result like that. And management of stage 5, again contributions. Look at from our country itself. I think Lingam Gopal was the first one to start this. He started long time back. He used to get totally frustrated and because we were so close, and he would say, I have started it, I can't stop it. But then that is the way it was to go about, even in that era, because very few would settle, or later on they would have issues, or they would not see. But then subsequently there are series from Shah and Narendran, as well as a recent one from Parveen and the same group. I think we have contributed a lot. Also, we keep on following, contribute on this. I think especially this article in 2008, this I had given thesis long time back. She was even senior to Anand. Isn't it Anand? She was senior, your senior. And she wrote finally when she went for fellowship with I think Arvind group in Madurai, isn't it? That is the time she wrote. And it is very well cited. And of course, these kind of sequelae can happen. And you have this kind of myopia happening. I think we need to work at all stages. Work at all and contribute. That is what we need to see. I think we have contributed in this manner also here. We have this, you can see up there, you all know about NeuRet. And studies are there. And not only that, it is working very well. And if you can identify a treatable and don't miss that, I think the job is done. That is what is basically required. And even, I must say, this MI-RET, it is being used on so many things. So Ashish Sharma has been quite smart, and many people are using his device for various things. Of course, not a wild field, but then at the same time, they can make it move, and there are these published studies you can see. So I think we have a lot of contribution as far as these kind of screening devices are concerned. And we have a problem. We have a increasing ROP blindness because of the many problems which we know it, increasing number of NICU, SNCUs, ROP treating. That's what we are trying to do. All of you know that. And now already probably there are around 800 SNCUs. We don't have programs really everywhere to screen them. And these are the fertile grounds for getting, that's why we are doing all this, what we are trying to do, what we are talking, what we talked earlier. And if you see like this, that is what I keep telling, and that is story perhaps. I used to see one baby once in a while when I started this program, and then started seeing maybe once in a month, then once in a week. The story was when I was in PGI, I was seeing minimum maybe 4 to 5 babies every week with stage 5. So I think we have to reverse that. If we don't reverse that, then we have a problem. Look at this study here, done by us and Professor Azad's group. I mean, which has 86 to 89% were never, they were never screened. They went to stage 5. That is where we are, what we are talking. And majority were picked up by parents when they noticed that a child is not seeing. And pediatrician referred none to 8.7%. In one study, none was referred by them. In other, 8.7% only were referred. And even ophthalmologists, between 26 to 86% referred them, but some of them very late. So I think we need to do something. That is why such articles are very important. We have to create that awareness. I think this has already been talked about, the Queen Elizabeth Diamond Jubilee Trust. I think this has helped us a lot, and that is what is going to help us. This is 2013 to 19, which was with us, and that is where that whole thing which you are going to have, exactly the way we're going to train people, the way we're going to do, has been done under this very program. And this has definitely, you can see, go through some of these things here, and it's not only for us. They have come out with great guidelines for the pediatrician, for the neonatologist. They have done a wonderful job. That is where this last publication is. And so I think you must go through these. This is in the recent article, the journal which has come out. I think we must feel proud. Something like retrolental fibroplasia, which nowhere existed, they gave us full 2 journals. One pediatric retina in June, which was in IJO, and 2016, whole, you see, Indian pediatric supplement, they came out with. So I think we have shown and we have contributed and we need to contribute more. I think we have now gone places. This I am just showing that we need to bring it across to Professor Azad. He always comes up with great fertile idea, and that's how we are here today, and that's what we are trying to do. There is something to do with PGI and ROP. I think all of us are from PGI, and that is where maybe I think it's had to grow somehow there. And of course, I could do because I had great people with me, great colleagues, my teachers, and they helped in every way. Maybe we had to sit this way only, the way we were, right? Professor Jain, who was our head, then Samud Gupta, Professor Jagat, and me. So I think I'm just concluding that we have contributed significantly as far as the ROP is concerned, but we need to contribute more. We definitely need to contribute more, and contribute in a way which is relevant to our country, and at the same time try a prospective study. If you do that, I think it has a major impact. And if you do something which is relevant to us, that is how Professor Anand's thesis in this article is the most cited, because of that we looked at problem which we had and which we found most difficult to publish anywhere. And finally, as a desperation, published in Indian Journal. So I think we need to look at, and we need to somehow do much more, and which perhaps our society is doing. Thank you very much. Thank you, thank you, thank you.